Thanks, Duncan. Actually, I want to start with sharing with you an experience I had at HIMSS earlier this year. I attended the interoperability symposium that happened the day before HIMSS starts. And we had on stage folks from HL7 and NIST and the CMS sharing with the audience all the federal initiatives to improve CDA interoperability and meaningful use, and how they're going to take meaningful use up a notch by monitoring, not just certifying EMRs, monitoring the EMRs in the field and whatnot. And about 3/4 of the way through the afternoon, it didn't feel, I've attended this symposium over multiple years, and this year just didn't seem quite as engaged as previous years. And at a certain point, this woman stood up about 3/4 of the way through the afternoon, and she just waved a stack of papers in the air. I don't know if any of you were there and saw this. She was the CEO of the Health Information Exchange for Kentucky. And she says, this is the list of all the meaningful use certified systems in the state of Kentucky, and I can't get any of them to exchange data with each other on my Health Information Exchange. What was the point of this massive meaningful use certification program when it doesn't work? So that's kind of the context for what I want to talk about today. Here in Canada, we often dream up these fantastical ideas of sort of pan-Canadian architectures and infrastructures and how it's all going to work. What I do for a living is I work with a software development, software services firm. And we're the folks that get stuck with actually the last mile problem of getting the data in and out of those endpoint systems and trying to make these fantastical diagrams, architecture diagrams, into something real and getting the data really moving. And so I'm the VP of Healthcare at a firm called Intellaware. We built the Shoppers Drug Mart system and integrated it across the country. We also did a lot of tooling work for Canada Health Infoway, and integrate systems in hospitals and whatnot. I also am on the board of ITAC Health, where I chair the Interoperability and Standards Committee. Last year we presented a position paper on interoperability from the vendor perspective, and so really try and keep on top of where the vendors are at. So that's what I'm going to talk about today. I want to start by taking a walk around the neighborhood of, I think there's really fundamentally kind of three different kinds of systems that we need to connect when we're talking about building electronic health records across the system. The first is the hospital information system. These are largely American software systems: Epic, Cerner, Allscripts, Meditech. Massive public procurements cost hundreds of millions of dollars to purchase these software systems, run them inside of hospitals. The second kind of system is almost the opposite extreme. It's what we have running in our doctors' offices. So these are not big American systems. They're homegrown, proudly Canadian, built little software systems, just built by mom and pop organizations that invented EMR and were enterprising, pounding the pavement, knocking on doctors' offices' doors and saying, here, buy my EMR. And but relatively small and limited capability compared to the big hospital systems. The last kind of system that we need to connect up for all this last mile work are the centralized provincial infrastructure. Ontario kind of lags behind some of the other provinces in this, but these are things like looking up a patient, looking up a physician, looking up what medications a patient's on, kind of these centralized infrastructures. The first big bite that Ontario took out of the provincial infrastructure was OLIS. We spent a long time building OLIS, and those of you who've been around for a while know that it took a long time to get it to work. Sorry. I'm sorry for those of you who may have worked on that project. But you know what I'm talking about. All right. So we've got these three kinds of infrastructure we need to connect. We've got to connect these big American hospital systems. We have these little doctor's office systems and the central provincial infrastructure. So hospital systems, as you're probably aware, largely use something called HL7 version 2. This has been around since the 80s. And it's a protocol. It started just within the walls of the hospital when you needed to communicate to a bed management system or to a lab. Moving information about the patient around inside of the hospital would use this protocol. It's really old, it's a sort of pipe caret delimited format. It's also really not very extensible. So as new requirements emerged, people tacked on their own proprietary fields called Z segments. Everybody did it in a different way. And now what we have across the province are all these HL7 version 2 messaging implementations that are very different from one hospital to another hospital. Those of you who have done hospital integrations, you know what it's like. There is kind of no one-size-fits-all solution to that problem. What happened after that, from inside, we saw an opportunity to actually exchange data between hospitals using HL7 version 2. So this might happen in a couple of regional hospitals that are cooperating and you want to transfer the patient from one to another. They might send an ATT message over. Or also we have lab partnerships where one hospital specializes in a certain kind of lab and they need to basically send the patient over to the other hospital to get that lab test done and whatnot. And so we can send the lab order across and back and forth. So we really have the beginnings of healthcare data interoperability happening here in Ontario in the hospital space of hospitals exchanging these V2 messages. But every time they do it, it's a point-to-point problem. You've got to get this vendor on the phone with that vendor and figuring out, okay, how do you guys do this? How do you guys do that? How are we going to code this to make it work? It's very expensive building any one of these particular pipes. So now I want to sort of take us to the year 2000. That was kind of mid-80s, 90s. Now up to the year 2000 is really when when Canada Health Infoway got kicked off with a mandate saying by 2015, every Canadian is going to have a shared electronic health record. All their physicians will have access to it. The patients will have access to it. We invested $2 billion and funded a whole bunch of provincial infrastructure, and as well as getting electronic medical record systems into all the doctors' offices. And so at that time, that was really when we had a big jump in the deployment of doctors' offices systems, these EMRs going into the doctor's office. Now, I often look back to that point in time and see it as a real missed opportunity because here in Ontario, we had a certification program run by Ontario MD that would basically set the bar for if you meet this level of basic requirement, then you qualify for the funding and you can be you'll be a sponsored EMR. The doctor can get money from the government to install the EMR. But this certification process had very little in the way of data interoperability, of getting data in and out of these doctor's office systems. And we're kind of now stuck with the legacy of that. The closest thing it had was something called the core data set, and I see people in this room who worked on that. But it was really not intended as a data exchange format to move data in and out of doctor's offices systems. It was meant as to avoid vendor lock-in, so that if you had a doctor migrating to a different product, there would be some way to export data from the one product and import it on batch into the other. And to my knowledge, it never really worked that well, and certainly couldn't function as the foundation for moving patient data for referral, for example. So the other part of the enthusiasm that happened in the year 2000 was the eHealth blueprint. Many of you have seen this diagram. And this is the kind of thing that makes developers like me cringe. Because I see this, and I see all the excitement. I saw this in so many presentations. And the folks they kind of glossed over, what is FHIR IEP standards to get the physician office EMR into this pile that's going to communicate with all these systems. It's all kind of glossed over. I felt like there was so much enthusiasm about building this, but not a lot of thought about the last mile implications of it. So now let's talk about what happened with these different systems. This is basically my picture of provincial infrastructure that was modeled after the blueprint. So we have the Heil across the top. This is actually a real building in Singapore. So we built these fantastical provincial infrastructures on a state-of-the-art, brand new technology called HL7 version 3. got these repositories, we have a HIL, we have consent management, very expensive, big framework. But again, a lot of effort went into building this provincial infrastructure, and the problem of how are we going to connect this into hospitals or doctors' offices, that's a problem that we'll solve later. So just to recap where we are, and this is sort of, I think, takes us up to about a couple of years ago. Where we are is we've got hospital information systems that can exchange data using this clunky HL7 version 2 protocol. And the other thing worth mentioning about this is that it's expensive if you want to do this. Generally, you have to call the vendor who's going to make a change to their system. They'll bill you out like $2,000 a day, and you typically wait 6 to 9 months for that work to happen. So you want to establish an HL7 v2 connection into a Meditech or a Cerner. I've spoken to so many frustrated hospital CIOs who just say they feel like they're held hostage. 9 months, $2,000 a day, you have no choice. That's what you're locked into. Similarly, we have these quaint little Canadian systems rolled out right across the province, but very little connectivity out of the box on those, except maybe submitting claims. And then lastly, we have this fantastical provincial infrastructure built on HL7 version 3 that really can't connect to any of these endpoints. Now I just want to move forward to where we are today, and I think a couple of interesting things have happened in the last couple of years in this space that have changed the landscape. So the first thing that happened was a couple of large Canadian corporations purchased about 70% of these doctor's office systems. I won't name them by name. We all know who they are. And but they actually did quite a bit of work with them. So they went from these little mom and pop development shops to a much more strategic corporate IT infrastructure, and started thinking about integrating the systems with each other, integrating strategically with other systems, and with the sort of the broader healthcare infrastructure. So these doctors' office systems have seen some investment and some modernization. So I think they've really moved forward. The other big thing that happened, and it's the topic for today, is FHIR. So FHIR really started appearing on the radar a couple of years ago, but even a couple of years ago was sort of a hobbyist curiosity, and now it's just taken the world by storm from a healthcare perspective. Like just going to HIMSS 2 years ago, 1 year ago, you just see that like FHIR is basically it. And the reason, as a developer, I understand, is because working with V2 or V3 was very, very expensive and cumbersome. And with FHIR, you're done in a couple of days. It's like, I'm not exaggerating, 15 times faster to work using these modern technologies. So another thing that's happened in the last couple of years is the province has started standing up some infrastructure using the new FHIR protocols, and these have been super successful. We've seen integrations that used to take years, take weeks, connecting into this new provincial infrastructure. All right, so just to wrap up here, I just want to talk about what's the path forward now, given where we're all at. First off, I think in terms of the provincial systems, the choice is really clear. We need to move away from the HL7 v3 fantastical architectures. We need to move towards having FHIR interfaces on all of our provincial assets. The sooner that happens, the lower the cost will be for anybody integrating into these provincial systems. The second thing, this one's a little bit trickier, is the hospital information systems. I know that the province right now has a hospital information system renewal strategy in play, where they're negotiating much larger contracts with these American firms. And this is an opportunity. I was just speaking with somebody earlier here who's in the middle of a hospital information system procurement. We must ensure when we buy these hospital information systems that they expose a published API for getting data in and out of these systems. We need to move away from the vendor lock-in where you have to phone them up and wait 6 months and pay exorbitant fees to get data in and out of these systems. We have to stop buying those kind of software systems. FHIR is really the best, I think, possible solution there. But at this point, I'd even just take a published, well-defined API to do it. So if any of you are involved in hospital system procurement, please don't let the purchase go forward unless you actually, and you don't just get a promise from the, oh yeah, we do interoperability, you actually see proof that yes, there is an exposed API for getting data in and out. And the reason I care about this particularly passionately is we build quite a few software systems for startup companies, and we need to deploy these into hospitals, and that's the barrier. We need to be able to exchange data between the startup systems and the hospital systems, and it's a big blocker right now. So like healthcare innovation needs this. In terms of the doctor's office systems, and I know one of the owners is following me on stage, I have a challenge out to these new owners. I feel like they're faced with an interesting and challenging choice. But on the one hand, by accumulating a lot of these systems and building a bit of infrastructure, there's a temptation to establishing a monopoly and proprietary closed systems, and allowing maybe some startups into that, but locking all the other folks out. But as an ITAC guy, as a developer guy, I really hope that the better angels speak to these folks, and they start thinking in terms of a published open platform, like an app store model almost, where there's an open API, and folks that want to exchange data with these doctors' offices systems just need to connect to this open published API. So that's it. I just want to sort of close with Goldilocks from a developer's perspective. HSM version 2, it's too hard. Version 3, you just get smothered in this awful softness, and FHIR is just right. So, thanks very much.